talk a little bit more about the etiologies, epidemiology, and risk factors. So pathologically, COPD affects the entirety of the respiratory tract. So it affects your airways as well as your alveoli. So in the conducting airways, chronic bronchitis results from the irritant effects of smoke, inducing expansion of the mucus-secreting glands. We'll talk about this a little bit later. In the terminal bronchioles, there is increased airway resistance caused by smoke-induced lymphocytic airway wall inflammation. Within the lung parenchyma, there is smoke-induced emphysematous lung destruction caused by an imbalance of neutrophil, macrophage, and interstitial proteolytic enzymes that damage the gas exchange units. Acute exacerbations of COPD, I'm sure all of us are familiar with these, may be idiopathic, infectious, or environmental in nature, and generally present with quite significant respiratory distress. Lung dysfunction results from dynamic hyperinflation caused by airflow limitation, together with loss of elastic recoil, increased collapsibility, and narrowing of the small airways, as well as impaired gas exchange. This then leads to a ventilation-perfusion mismatch, alveolar destruction, increased dead space causing the hypercarbia. And we know that COPD patients retain carbon dioxide. Reduction of the total minute volume and increased work of respiration due to airway resistance, hyperinflation, and ventilation perfusion mismatching result in alveolar hypoventilation, hypoxemia, and hypercapnia. Risk factors, we know, we mentioned cigarette smoking in about 90% of cases, but also those who are exposed to air pollution, biomass fuel exposure, occupational inhalation, and the infamous alpha-1 antitrypsin deficiency. Only about 15% of smokers go on to develop COPD. A genetic predisposition to COPD is also a likely contributory factor. That's a nice diagram here taken from Harrison's, which shows us the triggers, the effector cells, the biological pathways, the key molecules, and the pathobiological results. Oh dear. So triggers, we know, cigarette smoke and genetic susceptibility, right? And these then cause the effector cells to kick into action. You got the alveolar macrophages, the neutrophils, the epithelial cells lining the conducting airways and the alveoli, and you got the lymphocytes, right? Biological pathways is that, remember, we're going to have an imbalance of proteases and antiproteases, right? So proteases are bad enzymes. They come in, they destroy the walls of the alveoli, and they basically predispose to air trapping because they destroy the alveolar walls. Antiproteases inhibit the action of the proteases. So to maintain homeostasis in a normal situation, the antiproteases are supposed to balance the proteases. But in COPD and emphysema, the proteases dominate. The antiproteases are inhibited, and so we have destruction of the alveolar walls and hence air trapping. The net result there is an extracellular matrix destruction. We also have the battle between the oxidants and the antioxidants, with the oxidants winning that battle, giving rise to chronic inflammation. We have apoptosis of our cells, giving rise to cell death, and we have lung repair, which is not very efficient, and that leads to ineffective repair, which contributes also towards the air trapping and the hypercarbia. All right, here we have another humor slide. Have you ever wondered what a lizard smokes? Lizard smoke? Marijuana. Not marijuana, all righty. Okay, I do apologize.